Okay, မင်္ဂလာပါရှင် it's our great pleasure and privilege to invite Professor Griffiths for the second time to teach the medical students in Myanmar. And also thank you so much to Sia Thekuko and Sia Mat Sansan-U for inviting us to teach here. So Professor Griffiths, as most of you would know, is Foundation Professor of Dermatology at the University of Manchester. He has done groundbreaking research in psoriasis, aging, and others, and now embarking on global health endeavors through the Burma Skincare Initiative charity that we co-founded. So today is about going through the case-based discussion. So just to recap, the first session of teaching by Professor Griffiths went through the basics of dermatology 2 weeks ago. And last week, we went through the common and emergency skin disease in children and also common and emergency skin disease in adults by Professor Griffiths 2 weeks ago. So today is about going through, consolidating the knowledge that you have learned and going through individual cases, including those cases that we saw in Myanmar as well. Professor Griffiths, the floor is yours.
Well, thank you so much for the invitation to come back and talk to you again. And thank you, Sue, for that nice introduction. So the way I want to run this morning is interactive. And I don't know how we're going to do this, but I'm going to show some clinical images, and then I'm going to invite people to comment about what they think the diagnosis is, or to actually initially just to describe the morphology. And then we'll discuss the diagnosis and move on to the next case. And we have a lot of cases here. And as Dr. Lewin mentioned, some of those are ones, if we get that far, that she and I saw together when we were in Myanmar a couple of years ago. So let's begin. Let's see how we get on with this. So you'll remember that in my first lecture, we talked about how to approach the dermatology patient, the patient with a skin, with a rash or with a lesion, and the important components of the history, the important components of morphology. And I think what we, sort of one of the key messages was that it's very important to be able to describe what you can see in front of you. Because I think if you can describe the lesion or the rash accurately, that is halfway to making the diagnosis, because a lot of dermatological diagnosis is purely descriptive. That's very much the way that it is, but if you can describe it, then you are in pretty good shape. And also it's important to describe if you're trying to describe what you can see to maybe a dermatologist on the end of a phone. So this is the first case, and of course remember that we talked about adult dermatology a couple of weeks ago, and then last week Professor Malerio, last Sunday, gave a very nice presentation about pediatric common skin diseases in children and also some emergency pediatric cases. So this is the first case. I don't know if anyone, I don't know how we're going to do this, but that this, if anyone wants to just put in the chat, or you just have to say what you think it might be. Don't be shy, because you would have seen this before when Professor Malerio spoke last week. So I'm just trying to ascertain whether you've remembered much from what she said.
If I may, Professor Griffiths,
yes,
because
certainly,
I appreciate that a lot of them might be quite shy, and I know Sue A, I saw you and spoke to you yesterday, so I wondered whether Sue might be willing to volunteer for the first case, just to warm up the audience, because I think it's and also the host is saying that you can unmute yourself to talk if you wish to. Otherwise you can put your answers in the chat as well.
Hello, good morning.
Good morning.
I can see erythematous papular nodular lesion on the left upper eyelid, also involving the skin above the eye as well. Could it be a capillary hemangioma?
Yeah, so this is that's very good, Sue. So this is a you remember from last week that we talked about infantile hemangioma. So this is a young child, probably no more than about 8 months old. The parents are very concerned about this rapidly growing lesion, which is, as you can see, it's starting to affect the vision of this young child, and this would probably require treatment. These are common. They occur in about 4% of infants. They're much commoner in women, in girls for some reason. We don't know why that might be. And they're also commoner in children who are born with low birth weight as well, less than 2.5 kilograms. They will spontaneously involute, but of course, in this case, probably some form of intervention is required. And propranolol is serendipitously found to be a very effective treatment for these form of infantile hemangiomas. Vascular malformations, which are different, do not respond to propranolol. So good, that's a good description. The key things here is that it's a sort of a deep burgundy red, it's very well demarcated, and it's nodular, so there's very little epidermal change. This is all happening in the dermis, in the vessels. Let's move on to the next case. Right, who would like to have a go at this? I mean, there's no standing on ceremony, there's no right and wrong answers. The key is to have a go, try and describe it, and then we'll move on to what we think the diagnosis is, and then so we try and keep things moving along quickly. So who would like to have a go at this? No one's very keen on this. So when I talk like, so this is a symmetrical rash, very well demarcated. It's on the elbows. It's red. It's heavily scaled. You can see here the individual lesions have a very good demarcation. So it's symmetrical rash. This is in a young man, probably in his mid-20s. And immediately you have to think of papulosquamous skin condition. And this, of course, is coming down to, is this psoriasis or is it atopic eczema? Well, atopic eczema, the lesions are not as well circumscribed. They tend to occur on the flexure, the other side of the arm. So they tend to occur on the flexures, not on the extensor surfaces. So this is a very good sort of textbook, I would say. It has actually appeared in textbooks, textbook example of psoriasis. And interestingly, we don't know much about the epidemiology of psoriasis in Myanmar. And that's something that we in the Burma Skincare Initiative would very much like to do a study to ascertain how common psoriasis is there. When we were there, I think at the end of 2018, we saw several cases, some of which had really quite severe psoriasis. The key thing here is that this will be manageable with topical treatments, though, of course, any patient with psoriasis, one has to inquire about cardiovascular, cardiometabolic risk factors, such as hypertension, hyperlipidemia. And of course, a lot of these patients have psychosocial problems. So there's a high incidence of depression and anxiety. So if you can remember psoriasis, this is a very good example of that. Right, I think I'm going to be doing a lot of the work here today. So this is a young child, 13-year-old child brought to see me. The mother is concerned about these blisters. They've been to see the doctors in the accident emergency department who said they thought this was pemphigoid. Any thoughts so these are any thoughts what this might be? You can put it in the chat. Grace, do you want to have a go? So, yeah, you're going to try and get the troops to.
Well, absolutely. So sorry, yeah. So I mean, people are putting things in the chats. A lot of them are quite shy.
Okay.
So
I can't. I
just
can't see the
to
chat
say,
at the moment. That's the trouble.
No, don't worry. I will be. In which case, if you're happy with it, I'm sort of moderating the chats as we go along. So people are saying. So I just want to emphasize that it's not about getting the diagnosis here. It is about being able to describe what you see. So, remember what Professor Griffiths taught about, macules, papules, patch, plaques, vesicles, bully, blisters. If you can say these things. So now Grace said blisters.
Yeah, well, Grace is absolutely correct. These are blisters, or bully, B-U-L-L-A-E, as we call them in the sort of the Latin terminology. But these are very good examples of blisters. And I think the key thing here about these blisters is that they're occurring in a young, well, sort of a child. They are symmetrical. They're occurring on both legs, and they are very well circumscribed, and there's no evidence of erosions. So when you see a case such as this, and as I mentioned at the beginning, when someone like this turns up in an accident emergency department, they all get excited. They think it might be pemphigoid. And remember, we talked about this a couple of weeks ago about pemphigoid being an autoimmune condition where there's antibodies to the components of the basement membrane. Well, this is a child who's had these for about 6 months. They're very itchy. And the cause of this actually, this is called papular urticaria. So these are the consequence of insect bites, a very dramatic response to either insect bites or flea bites. So not pemphigoid. Maybe later on we'll talk about other blistering conditions in children. So yes, you're absolutely right. These are blisters. So you've made a key part of the diagnosis here. You already said they're blisters, so that excludes a lot of other skin diseases. So in this case, the patient would be managed by eradicating the fleas at home. And this child, there was a cat that they just had they had as a pet, which they had only been at the home for about 6 or 7 months, and the cat had fleas, and the fleas then caused this very exaggerated response. Right. So a lot of dermatology is linked to internal medicine. So if you can, quite often we can make the diagnosis of a systemic complaint by the lesions we see on the skin or cutaneous manifestations. So here's a person with here's a tongue in a person in their 60s. Anyone want to describe about this tongue? First of all, is this normal? I can imagine you're all looking now in the mirror to see whether your tongue looks like this. I can tell you that your tongues don't look like this. And if they do, we will talk about what further investigations you require.
Already in the chats, they're saying strawberry tongue and atrophic glossitis.
Right, so
shiny tongue.
Yeah, so very good. So strawberry tongue is different. It looks like a strawberry. You see little papules of the strawberry, you often see with measles. But this is a shiny tongue. You can see the way the light is reflecting off the tongue here. So there's no papillae. They've been lost. So this is a glossitis, an atrophic glossitis. So that's a very good description. So immediately you start to think about conditions that might cause atrophic glossitis. Anyone got any thoughts about that? So if there are a couple of tests that you would need to do.
B12 deficiency, one saying.
Yep.
Folate
absolutely.
Deficiency, iron deficiency.
Yeah, absolutely right. So those are the top ones. B12 deficiency, iron deficiency, and this is a person who is iron deficient. They had a very poor diet, and this was easily rectified. So they had an iron deficiency. What about this? This is the for the next few slides. So this is the next patient we see, and they're very concerned about the color of their tongue. They've been to see their general practitioner. They might have melanoma. Now, this is a person who, again, lives on his own. He's doesn't look after himself very well. Anyone want to describe what they can see here? Now, this isn't a normal tongue, is it?
Someone said meaty tongue, but they probably...
Yeah, it's no, I wouldn't say meaty tongue.
Discoloration.
Yeah, so there's a discoloration, and the standout feature here is that the discoloration is black. It's black, dark brown, and this is sometimes known. So that's the key thing. So the dermal papillae looks, the papillae on the tongue look normal. So this is not atrophic like we saw before. This is black, and the patient for some reason only just noticed it, and GP got very concerned. And so this is what's called black hairy tongue. This is nothing to be concerned about. This is just due to poor oral hygiene and is easily treated just by better oral hygiene and actually just scraping this with a toothbrush, and that will clear it up straight away. In fact, when I was doing a WhatsApp clinic in a Bangladesh refugee camp not so long ago, there were a couple of cases of this, and this was easy to rectify. All right, so the third case we see in our oral medicine clinic is this one. So this young man is concerned about the appearance of his tongue. It is a little bit painful. Anyone want to describe what they can see, what they think this might be? Now, this isn't like the last two we saw, is it? This is quite different.
So Muir said, sorry, geographic tongue,
Yeah.
candidiasis, oral thrush, multiple ridges.
So those are all good suggestions. Oral candidiasis you have to think about, but the thing that's unusual about this is that the patient says it's a little bit painful, and also he said that it tends to move about. You know, yesterday this was different than it was the day before. So this is, yeah, the diagnosis is correct. It's geographic tongue, so it looks a bit like sort of outlines of different countries, or benign migratory glossitis. Underlying causes of this, sometimes it can be associated with an allergic response. Usually we don't know what the cause is. There is a literature that says it's linked to psoriasis. It's not a form of psoriasis, but for some reason patients with psoriasis do seem to have this more commonly than the normal population. So those are three sort of common tongue problems to help you. All of two of which are one, this resolves on its own. Black hairy tongue you can treat very easily, and the glossitis is you have to do further investigation. All right, so this is the.
Sorry, Professor Griffiths. So a question from you saying how is it different from thrush?
So thrush wouldn't be quite so well coated, and also you wouldn't get these sort of these. You see these very typical. I think you can see the pointer here. This sort of serpiginous edge here, and also if on the history they'll say that it's changed. It differs from sort of week to week, day to day. And if you look on the oral, on the buccal mucosa, you can't see this. There would be no lesions there. Whilst often with oral thrush candidiasis, there'll be involvement of the buccal mucosa as well. But that's a very good question. Okay, let's move to this next case. I'm trying to keep things moving along here. So this is the shin of a 38-year-old lady. This is a painful lesion. It's come up over, it's about 5 centimeters in diameter, maybe a bit more than that. It's painful. It's come up over the previous month. Anyone want to have a go at describing what they can see before we move on to other things? So this is, what sort of lesion is this? Is this a plaque or a patch, or what is it? How would you describe this if you had to describe this over the phone to a consultant dermatologist? And
can I say there's a single wall circumscribed ulcer with irregular edges, and there's a raised peripheral border, which is gray in color with a sloughy base in the center.
Yeah, so that is a beautiful description. So you've captured all the salient features here. So it's well circumscribed. It's got this raised rim, hasn't it, which is a sort of gray purple color. And the center is an ulcer. This is the term I was looking for. So this is ulcerated. This is down into the deep dermis. There's a lot of slough there. And there's some sort of pustular area here up on the right. Hope you can see my pointer. And it's a little bit purple here. So this is on one shin. This is painful, well circumscribed. Any thought what this might be?
Could it be necrobiosis lipoitica diabeticorum?
Very, very good. Yeah, that is in the differential for certain. If it had been on both shins, then I'd have said, you know, that would have been a much more likely. Necrobiosis lipoitica diabeticorum tends not to have this sluffy base. It tends to be much more indolent, taken a long time to develop. So this is what other conditions? So this is a link to systemic disease. So if I told you this woman had sorry, go ahead, whoever that was. Yeah.
Yes, pyoderma gangrenosum. What about it?
Yeah, excellent, brilliant. So hand well done. So this is pyoderma gangrenosum, and this is linked to inflammatory bowel disease, very strongly linked to inflammatory bowel disease, particularly Crohn's disease, ulcerative colitis. Though not all patients have that, and of course not all patients with inflammatory bowel disease get pyoderma gangrenosum. It's also linked to hematological malignancy, rheumatoid arthritis, and other arthritides. Quite often, though, we don't find an underlying cause. The differential here, the thing that should always be excluded, even if the patient might have inflammatory bowel disease, is a squamous cell carcinoma. So every case should be biopsied. I think that's important, just to exclude a malignancy. So yes, this is inflammatory. This is pyoderma gangrenosum, and this responds very well to anti-TNF biologics or systemic steroids or cephalosporin. And doesn't really track with how well the inflammatory bowel disease is controlled. But yeah, but very good. This is an important cutaneous manifestation of a systemic disease, namely inflammatory bowel disease, pyoderma gangrenosum. And the classic feature is this well circumscribed, raised purple gray edge with a sluffy ulcer in the middle. Sometimes it can be more than one lesion. Right.
Sorry, Professor Griffiths,
yeah,
would you
yes.
like me to go through ask the questions as we go along, or at the end? I think might be best to do the questions as we go along, do you think? Or?
Yeah, let's do the questions as we go along, because I'll probably forget what I've talked about.
Two questions about this. How do you
Yes.
differentiate PG from necrobiosis lipoidica? And also, how do you differentiate it from SCC?
Well, so the necrobiosis lipoidica diabeticorum tends to have well circumscribed every, it tends to be shiny, maybe atrophic skin, tends not to ulcerate, does rarely see it ulcerating like this, is usually been present for quite a long time, quite often symmetrical, i.e. on both shins. And of course, NLD, as the terminology we use, necrobiosis lipoidica diabeticorum, is linked to diabetes. About 1 in 100 people with diabetes have NLD, necrobiosis lipoidica diabeticorum, or about 50% of people with necrobiosis lipoidica have diabetes. So it's not always linked to diabetes. Squamous cell carcinoma, I think the often difficult to tell, particularly if it's a small lesion. The only diagnostic is a skin biopsy, and that's why I encourage anyone who, even if you think it's pyoderma gangrenosum, always best to take a biopsy, not because there's absolutely characteristic pathology, but to exclude other pathologies. I've been caught out like that. I remember seeing a young woman with Crohn's disease who had a 3 centimeter lesion on her shin, which we said, oh, it's pyoderma gangrenosum, and it turned out when it didn't respond to cyclosporin, then we went back and biopsied, and it was the squamous cell carcinoma. So, but squamous cell carcinomas tend not to have this purple edge. This is very characteristic of pyoderma gangrenosum. But those are excellent questions. Let's move on. Okay, so this is a 30-year-old woman in a refugee camp. She's got this lesion, this rash on her abdomen. Anyone want to have a go at describing this? Anything coming through on the chat? If not, there's 2 key things here. One is that it's fairly well circumscribed. There's some post-inflammatory hyperpigmentation. Remember, Professor Malario talked about post-inflammatory hyperpigmentation, particularly in darker skin types. But also there's a lot of scaling here as well. Hopefully you can see that. So this is extensive scaling. There's a bit of an edge to it. and it's been going on for quite a long time.
Absolutely, and there is certainly comments from the audience saying tinea. Another one said eczema and discoloration. So they've touched upon
Excellent.
salient
So
features.
absolutely excellent. So all three of those are important learning points. So there's the discoloration, which is the post-inflammatory hyperpigmentation that we just discussed. And then the differential here is this eczema? Could be. Is it psoriasis? Could be, but again, it doesn't have that sort of classic those scaling plaques. And in this individual, absolutely correct, it was tinea corporis, ringworm, and this being so extensive, we had to treat this with fluconazole actually. But tinea corporis is extremely common, but don't exclude other less common diseases such as psoriasis, but common things are common. So those are three very, very good comments. But and sometimes this gets treated with steroids to begin with, which makes it harder to diagnose, but you can nearly always find the active edge. And if it's been treated with steroids, it takes on this rather strange name called tinea incognito, which means tinea which is undercover. Good. Right, now here comes another abdomen, very similar. Who wants to have a go at describing this? This is a young man in his he's young, he's in his mid-30s actually, and he presents with this. So anyone want to have a go at describing this rather startling pattern that we can see? How would you describe that?
So
Sorry, there's a patchy or network-like lesion, network-like rash occupying over the lower half of the chest and the abdomen as well, with some rashes in some areas.
Yeah, so exclude this. I think that this is the key thing to us to look at. So you describe the key morphology, which is a did you say net-like? Did you say that? Is that the word you used? Network, you said. Is that right?
In fact, there are a few in the chats, Professor Griffiths, saying reticular. Nailed it. And
yeah, so reticular, net-like, net-like. This looks like a net, doesn't it? So the term we use for that is reticulate. And again, as we described before, there's some post-inflammatory hyper and maybe some hypopigmentation. So it's a reticulate network pattern of dark and light colored skin. Any thoughts what this might be? So there's no scaling here. It's not raised. He's had this for quite a while. He's had this for a year, and he's concerned about it.
Could it be erythema ab igni, but it's on the...
Yeah, so this is a very good. So this is a condition called erythema ab igni. I don't know if someone put it in the chat, IGNE. So this is a response to infrared radiation. So we see this people who, so this young man had some stomach pain on and off over the year. So he has been putting a very hot water bottle on this site. And that was it was the infrared heat that was causing this change in color of the skin. We see it sometimes in elderly people who are cold and sitting close to a fire. You see it on the front of the shins. So that's another rash one can see on the front of the shins. And this is really, the pathology is not well understood. It's probably a form of vasculitic rash. The important thing about this is that in some cases, when there's been a lot of heat applied over a period of time, they can develop squamous cell carcinoma. So this is exogenous caused. Usually it's of no great concern, but it resolves pretty much if the patient or the individual stops using the heat source. So erythema ab igni, but the key thing here is this reticulate net-like pattern. It looks like a fishing net, doesn't it? Right, very good.
Question, Professor. Can it be due to antiphospholipid syndrome?
I understand why you're saying antiphospholipid syndrome. It would be unusual to look like this, actually. I think in this particular site, you can see similar lesions on the when there's been a vasculitis, which you can see with the antiphospholipid syndrome, which is obviously linked to lupus. But just a localized area of this I don't think would be diagnostic of antiphospholipid syndrome. There'd be other features and more ongoing vasculitis and maybe some infarction.
Two other questions. So I guess it's linked to, you've already touched on it. So how do you differentiate this from livedo reticularis? And then the second question is about whether or not erythema abigne can manifest in different morphology.
Livedo reticularis, it is different from that. I don't think we should get down into too much detail with this, actually, but it's a different condition. And then as far as manifestation, did you say due to other morphology, did you say?
Can it manifest as a different morphology other than the reticular network?
No, usually this is the classic, yeah. Okay. Right, so this is, we're now going to go to the oral medicine clinic, that's AURAL. So this patient comes in to see us, and his left ear is very painful. This is a man in his 50s, very painful left ear. Anyone want to have a go at describing this? Don't be shy, there are no wrong answers here.
They're saying edematous erythematous here.
Yeah, so the two key features here, well, there's three key features. One is that this ear doesn't look normal, does it? So it's red, so it means it's probably inflamed. It's usually, if something's red, there's an increased blood flow, and it is also a little bit swollen, isn't it? You're losing the definition here between the rim and the concha. But what is the other? So the key question to you is the whole ear involved? Okay, I can see the chat now. That's good. Okay, yeah.
Just the upper half.
Oops, sorry. Let me go back from that. Sorry, what was that? Just tell me what was in the chat there.
It's involving just the upper half of the ear.
Yeah, so you're absolutely right. So it's involving just the upper half of the ear. This lower part, the earlobe, looks normal, doesn't it? It's certainly not the same as the rest of the ear. So how would you ascertain what does that help you? Do you think that maybe there's been some sort of contact dermatitis? Just, he's maybe wearing some earphones and he come down to this part of the ear, or do you think there might be something else going on here?
Somebody said perichondritis. But
perichondritis, yeah, you're getting close to it. If I told you this man was also having fever from time to time, and this wasn't the first time that he had this condition. He'd had it before. It had come and gone previously.
perhaps they meant poly rather than peri.
Yeah, so if you thought it was polychondritis, you'd be absolutely right. So this is relapsing polychondritis, and the key thing here is, of course, you only get inflammation and swelling where you have cartilage. The lower part of the ear, the earlobe, is fleshy. It doesn't have cartilage there, and that's why that looks normal. It can often be quite a systemic disease. It can affect joints. It can affect the heart as well, a respiratory tract. So it can be a very serious condition. But the classic thing I wanted to really show you was the sparing of the earlobe. And obviously there's a number of different ways of treating this. Dapsone, corticosteroids are used, but it's a matter of also investigating for other potential signs or symptoms of polychondritis. So this is to test your diagnostic capabilities and you got it right. Red, swollen, painful at the top where the cartilage is, absolutely fine where the earlobe, in the earlobe. Good. Relapsing polychondritis. Let's move on if we can. Oops, I seem to have stopped advancing here for some reason.
Is it autoimmune is the question, Professor?
Yeah, it is autoimmune. Yep, it is autoimmune. There's probably antibodies to collagen 6. Okay, next case. Young woman. She's 16 years old. She's very concerned about this rash. Who wants to describe what they can see? There's lots of things to describe here. So
They've got the diagnosis, but I think description is
okay,
key
they've
here.
got the diagnosis, though they've got a diagnosis maybe. I mean, so they've got pustules here. There's lots of pustules. They've got some papules. That's red little papules, inflammation. There is there's some scarring, ice pick scarring. We talked about that before. You can see this little scars here. This has been going on for a little while, but also the pathognomonic sign here is there's a comedone or blackhead. So I guess in the chat someone might have put acne. Is that correct, Dr. Lewin?
Absolutely, many people have
Yeah.
said acne.
Yeah, so that's good. So yeah, this is, I just wanted to test whether you're so this is acne. Not much else it could be. Yeah, young woman, and the pathognomonic sign are the comedones, which you don't see with a condition that can look similar from occasionally, which is called rosacea. But the comedones are classic for acne because the acne lesions always start as this blockage of the pilosebaceous duct by keratinaceous material. They're black, not because of dirt, but because of melanin that's trapped in there. And then that sets up that inflammatory reaction, and particularly organism there called Propionibacterium acnes. Treatment, topical treatments containing benzoyl peroxide, topical retinoids if they're available, and sometimes we use systemic antibiotics, not so much because of their antibiotic properties, but because often they're anti-inflammatory, the tetracycline class particularly. And if it's very severe with severe scarring, then if it's available, then Roaccutane 13-cis-retinoic acid can be used. And that's been one of the major advances in our treatment of skin disease in the last 30 years or so. All right, let's move to this case. So this is a patient who had acne, and they were concerned that on both shins, ignore this little bit in the middle, this is where an overzealous registrar had done a biopsy, should have done an ellipse. But on both shins, they developed this rash. Anyone want to have a go at describing this rash? Anything in the chat there? Let's have a look. Someone said black patch over the shin, bruise. Yeah, it'd be unusual if it, and so it's discoloration. All of these are right. It's on both shins, absolutely correct. It's a discoloration for sure, and it's symmetrical. I think that's the key thing, that you can't see it from the picture. I told you that it was symmetrical. So makes it more likely to be an internal cause. So if something is asymmetrical, it's more likely to be externally or exogenously derived. So this is something that's coming from within. The patient has acne or did have acne and was put on a particular treatment for their acne, which has produced this. And if you're describing it correctly, it's not well circumscribed and it's a bluish gray discoloration. I hope you can see that. Obviously, the important thing here, and even in, so this is in dark skin. Remember, we discussed last time that even erythema, redness or pinkness that we see in psoriasis can look gray in dark skin, but this in white skin, same color as my skin, would still look blue gray in color. So this is a person who's had acne, put on a certain treatment, developed this rash on both shins. Any idea what might be the cause? So
In the chat, tetracycline induced discoloration.
yes, absolutely correct. So this is minocycline induced. So this is the blue-gray discoloration that you can see with particularly minocycline. And this will fade with time. So it's something when you're putting patients onto minocycline, much less likely to occur with ordinary tetracycline, such as limecycline or doxycycline, that you should always advise them about this. This might happen. All right, let's move on to the next case. Okay, now hopefully you can see this. So this is a young man in his 20s. He is concerned about this lesion that he's developed under his eye, under his right eye. He's extremely worried about this. Any thoughts what this might be?
Someone mentioned
Or,
BCC.
actually, before we go to what you think it might be, anyone want to try and describe it? What have we got? We said, so first, actually, someone, Harley asked, how long does the discoloration take to disappear? It can take a few years, actually. So now so this lesion, people are saying, is it a skin cancer, such as a basal cell cancer or a squamous cell cancer? Is it reddish brown discoloration? So the discoloration is not really, it's reddish brown, I guess. It's more a purple discoloration though, isn't it? We can see here. And it's sort of a plaque, isn't it? It's not a skin cancer, but it's important to think about that, particularly in an elderly person with sun damage, and this would be a classic site for a basal cell cancer. I should have shown some skin cancers, but basal cell cancer usually has a raised, well circumscribed edge. It's a pearly edge. This is a plaque, isn't it? I describe as a plaque, a little bit of scaling, but it's a plaque which is sort of reddish brown, purple in color. So this is a purple plaque on the face of a young man who is inordinately concerned about it. Any other thoughts about this? So supposing I showed you, otherwise it doesn't seem to like advancing unless I go back. I don't know what's going on here. Hold on. Now this is his foot. So he's also got these lesions on the foot as well. I don't know how well you can see this. So his doctor had dismissed this as being warts. But hopefully you can see that these are a little bit more than warts. There's a little bit of purple discoloration here and little papules and little papules on the foot as well. That's a good example here. So any thoughts? A young man who's got a purple plaque on the face and he's got these little reddish papules, vascular looking papules on the sole of the foot. Anything in the chat
Someone
here?
thought that it might be of infectious etiology. Others have described as, yes, raised papule, round pustules.
Yeah. Okay, so this doesn't like to advance. Hold on. Some reason to make it advance, I have to go back. Right, so this is Kaposi sarcoma. And the reason this young man is so concerned is that he knows that this is what the diagnosis is going to be, and he knows that this means that he's HIV positive, and that's exactly what was the diagnosis. Kaposi sarcoma is poorly named. Actually, it's not a sarcoma; it's just a vascular proliferation. So the lesions themselves are not cancer or malignant, but they are. When I first started dermatology, we looked after the very first cases of AIDS in the United Kingdom. And these young men often presented with these plaques of Kaposi sarcoma, sometimes in the mouth as well. And those lesions I showed you on the foot were also Kaposi sarcoma. Up until that time, we'd only ever seen Kaposi sarcoma in elderly men from Eastern Europe, where they occurred on the lower leg. And it's linked, we don't see it so commonly now with HIV, I have to say. It's still linked to in people who are drug addicts, and the virus that causes it, which is Kaposi sarcoma herpes virus, or used to be known as human herpes virus 6. So purple plaque, is a sort of a signal that you should just think a little bit more carefully about whether this individual might be HIV positive and look for other signs of that infection. All right, let's move on. Now, I'm not going to go on with, so this, anyone want to have a go at telling me what this is? So this is a symmetrical rash on the legs, been there for a year and a half. It's a little bit shiny, it's well circumscribed. I've got another picture of another one. This is another case, very similar, it's the same condition. Right, I'm not going to go into any great detail here. So this is what we were talking about before in our differential diagnosis of pyoderma gangrenosum. So this is necrobiosis lipoidica. And remember, this is 1% of people with diabetes mellitus have this condition, and about 40 to 50% of people with NL, with necrobiosis lipoidica, have diabetes. So it doesn't always track with that. Doesn't always track with keeping the diabetes under good control either. Often quite difficult to treat. We treat it with topical corticosteroids, sometimes under occlusion. And the key is to try and prevent further spread because it's to prevent further atrophy as well. So that's another important, another clinical sign, cutaneous sign of an underlying cutaneous, underlying systemic illness, in this case, diabetes. All right, let's go to this. So hopefully you can see this. This is a man in his 50s who presents with, he comes to our dermatology clinic with this, but he's had this for quite a long time. Any thoughts what this, well, actually, before we go what thought it is, anyone want to describe what you can see? Does this look normal? No, it doesn't. What's the sort of standout feature that you can see here, in addition to the fact that he's probably a little bit sun damaged and may also be a smoker?
Patchy brown black discoloration over both lips. Could it be tar stain over the lips?
So he's got black brown macular lesions on the lips. Is that what you said? Actually, yeah, that's absolutely correct. Now this isn't normal, is it? So he has no other lesions on his skin, not that we can see in the dermatology clinic anyway. This is any thoughts what this might be? Just have a quick look at the chat. Yeah, there it is. Frida, great job there. Peutz-Jeghers disease, exactly, everyone can see that in the chat. So that's the spelling, Peutz-Jeghers. So this is an autosomal dominant condition. It's linked to malignancy. This is the key thing about this, and that it is linked to hematomatous polyps, particularly in the GI tract. It's rare, and the commonest cancer that arises from this is colorectal cancer. It can occur in other sites as well, but particularly GI tract, and also breast cancer. So this is Peutz-Jeghers polyposis, which is I'm trying to remember the mutation. I think it's something called STK something, which is a tumor suppressor gene. Right, so very good. Peutz-Jeghers, that's another example of cutaneous manifestations of underlying systemic disease. So you can see what I'm trying to do here, show that how important, whatever you do in medicine, even if it's not the best specialty of all, which of course dermatology is knowing something about dermatology is going to help you in making your diagnoses. And someone asked what is the best book? Well, I think Dr. Louis might be able to put that in the chat. So let's go to this. All right. So this is a woman who comes to see us. She's got these lesions on both flexor forearms. Okay. And they're very itchy. Anyone want to have a go at describing these? So everyone's thinking psoriasis here. So that's a good thought, and then Han said lichen planus, and Joe has said eczema. So Han, that's very good. Lichen planus. Now, we didn't talk about this last week, a couple of weeks ago, because we sort of partly ran out of time, and also I thought it might be a little bit unusual for you to see, but this is lichen planus. And it sounds as though it should be like something you see on plants, but lichen, it looks like lichen which grows on rocks. So this is itchy condition. The lesions seem to be sort of a purplish red color. They are flat. Can you see these are flat and have a little bit of tracery of scale? And sometimes they demonstrate something called Koebner phenomenon, which we also see with psoriasis, where they get lines in, it occurs in lines of scratching. You hope you can see there's a little line here. So these little striae over the top of the lesions are called Wickham striae. And if you see something you think it's got lichen planus, the other key place to look is where? Anyone want to have a go? So if you've got somebody who can see it's got lichen planus, and you're allowed one other place to look to sort of try and confirm your diagnosis, where would you look? You can put it in the chat if you want.
Oral mucosa.
Yeah, so oral mucosa, absolutely right. So, all right. And we look in the oral mucosa and we see this. Is this going to help you? Was that Dr. A, Sue? Was that you who said that? Yeah. So, yeah, so you've got this tracery of Wickham striae in the or on the oral mucosa, the vocal mucosa, and that is classic oral lichen planus. You don't see in every case of lichen planus. It's about 40% of cases, but this would be the clincher. This would make the diagnosis for you. So two things about lichen planus. Some countries it's linked to hepatitis infection, but most cases we don't know what the etiology is. Very itchy. There's classic lesions. Has Koebner. Treatment can be difficult by topical steroids or even systemic steroids if it's widespread. And some people present purely with lichen planus of the oral mucosa. And if that is chronic, then there's a concern that that chronicity of inflammation might lead to oral squamous cell carcinoma. So lichen planus, common skin condition, can present to any specialty. Right, here's the next one. So it's a very interesting clinic we've got today, all sorts of great stuff. This is the foot of a young woman who had been on holiday. Now, of course, you would see this in Myanmar from time to time. We don't see this in the UK unless the person has been on holiday. But what I want you to do is describe what you can see here. And it's itchy as well.
There's a serpentinous pattern.
Oh, so Frida, yeah, you've done very well here. Frida's got straight onto it, cutaneous larva migrans. And I guess, so obviously this is something you know about. And so Serena, Harley, Frida, and also Sue, you've all jumped on it. Of course, what we like to try and do is not go straight to diagnosis. We want to try and describe what we can see. So this is serpiginous. This is a great example of serpiginous. So it looks like a snake. It looks S-shaped. And you can see here that it's maybe started here and tracked along all the way through here. So this is serpiginous lesion. This is the serpiginous lesion of cutaneous larva migrans. And often see this on the feet and on the buttocks. And I've seen more cases, I think, on the buttocks than on the feet. It's where someone has been on a tropical beach, sat under a tree where the sand is still damp. And what is the cause of this? Anyone want to put that in the chat or say what they think it is? So serpiginous, thanks Dr. Lewin for spelling that out. Okay, so the cause of this, I don't know, I think you do see it in Myanmar. If I can get this to advance, it seemed to give me a hard time. This is today. I've got a nice little picture for you from the Center for Disease Control. So this is for, these are hookworms, Ankylostoma caninum or brasiliense, which you find in dogs and cats. It's found in the eggs are in the feces, or the larvae are in the feces of dogs and cats, and then they've defecated under a tree at the beach where the person has come and sat, and then the skin has been penetrated. So the lifespan, it's not, they cannot migrate into the intestine. It can't actually cause profound infection of the human, but it produces this very itchy, unsightly rash, and treatment is with mebendazole, sometimes ivermectin. But we do see it from time to time. Do you see this in Myanmar? I think you do. Of course, I've not seen it there. Yeah, albendazole, thank you, Sue. And ivermectin also works for this. Anyway, I think you might see this from time to time. All right, how are we doing here? Let's try and go to another case, shall we? Right. How are we doing for time here? I've got a few more minutes. Is that right? Are we okay? Yeah, we've got time for another case or so. So this is so this is a man that Dr. Lewin and I saw in Myanmar last time we were there, and he has had this rash on his back, also on the chest as well. Anyone want to have a go at describing what they can see here?
Serena said multiple silvery lesions.
Yeah, there are silvery lesions, yeah. But these aren't plaques so much. It looks as though there's been a little bit of skin loss here, doesn't there? So it's got an edge. It looks as though it's advancing here. And this is a bit difficult for you. This is so. What else have we got? Yeah, psoriasis. Psoriasis is in the differential diagnosis, but then we looked in this man's mouth. There's significant lesions in the mouth as well. There are erosions in the mouth, and this next case is of the same disease. Another case that we saw when we were in Myanmar the first time. So this is hopefully you can see on the neck here, this woman who's in her early 60s. You can see these erosions here, and then these what have been erosions, the encrusted lesions on the face and going up onto the scalp. Anyone want to have a hazard guess what this is? There were no blisters. So this is pemphigus. Remember we discussed it a couple of weeks ago. So pemphigus is where it's an autoimmune condition. It seems to be particularly common, or more common. It's still not a common disease, but we did see more cases than we were expected to see when we were in Myanmar in a couple of years ago, and also in 2018. And so this is pemphigus, which is an autoimmune condition, antibodies to the protein, the desmosomal proteins that hold the epidermis together, which anchor the keratinocytes to each other, called desmoglians, DESMOGLEIN. And this is with pemphigus vulgaris, you get lesions in the mouth. And if it's foliaceous, which is much higher up in the skin, just to desmoglian 1, you tend to just find very superficial erosions and not so much oral involvement. And people always get confused between pemphigus and pemphigoid. And last time we discussed that. So pemphigoid is where the antibodies to basement membrane proteins. So the roof of the blister is the whole thickness of the epidermis, which is why you see blisters in this condition. In pemphigoid, whilst with pemphigus, the blisters are higher. The roof of the blister is maybe just a few cells thick because it's high up in the epidermis. And treatment is corticosteroids. Pemphigus is much harder to treat and may be life-threatening. I think we've got time for one more case, I think. Let's do this one. So this is a young man I saw in Lebanon, actually. Who wants to have a go at describing this? And the same condition, I'll just show you just for sake of completeness, the same condition is in this next patient I saw in Lebanon, which is this young woman, this young girl, she's in her teens. She'd had a similar rash to that man, but is left with these scars. So who wants to have a go at describing what they can see here? And again, I do think there are cases of this seen in Myanmar as well. So you should be on the alert for this. Anything, what's coming in the chat? Crusted shaped lesion, yeah, very good. So there's crusting. There's an annular sort of serpiginous, well, it's an annular edge to it, isn't it? And scarring, yeah, very good. These are sort of, obviously it's a scarring condition. Erythema multiforme, Harley, that's be unusual actually, highly unusual. Think about erythema multiforme tends to affect the hand, the palms and the soles, also other areas as well. Erythema multiforme has target lesions, but like if you've ever played archery, you've got a target, so you've got a sort of a dark center and then concentric circles around the edge. So this is serpiginous, or this is arcuate, annular, isn't it? You can see the edge here, red, and then there's some scarring developing here as well. And any thoughts what this might be? I wouldn't. So very good, Frida, you've got it. So this is cutaneous leishmaniasis. Of course, this due to the vector is the sandfly. This is a protozoa, and this is not the same as visceral leishmaniasis, or cala-azar, which affects the liver, particularly in internal organs. Cutaneous leishmaniasis tends to affect just the skin. In South America, in the New World, there's mucocutaneous leishmaniasis. So you should recognize that in the UK, we only see it in people who've been traveling, and they have just a single lesion, but this is the more classic form of the arcuate lesions, and then the blistering, and then the scarring. Okay, I think that we've gone just over the hour now, but happy to take questions about this if you want, or what we can do if you're interested, if you found this helpful. It's a bit of a sort of potpourri of all sorts of different dermatological conditions, but I think that's the great thing about dermatology. It's every clinic, you never know what you're going to see. There's all sorts of, there's the common things and there's the rare stuff, and it's all around being able to take a step back, describe what you can see, and then working on the morphology, come down to the most likely diagnoses. But I'm very happy to do this again for you with some other cases. I have lots of clinical cases which we can talk about. And, I think the chat seemed to have worked pretty well, particularly once I got the hang of it as well. Any other thoughts here? Dr. Lewin or Dr. A, anything we should, so Serena wants me to continue, so I'm very happy to do that, of course. Any other last thoughts here? Otherwise, we'll wrap up for this morning. Well, morning in the UK, late afternoon for you, but thank you for joining again today.
Thank you so much, Professor Griffiths. Serena, absolutely. Hopefully in the future we can continue with the dermatology sessions depending on the demands, because we would like to teach more if you feel that this is helpful. Please complete the feedback survey. We strive to make it better for you. And tomorrow, same time, there will be 2 clinical specialist nurses in dermatology going through the practical tips on how to manage common and emergency skin disease. So using topical treatments, dressings, swabs, how to take swabs. So essential, practical, basic management of skin diseases. So hopefully see you tomorrow, 9:30 sharp. Okay, yeah. Thank you so much. Take care.
See you tomorrow. Okay,
Bye-bye.
Bye. Bye.
Thank you so much, Dr. Griffith.
My pleasure.
Thank you.